An exchange transfusion involves removing aliquots of patient blood and removing with donor blood in order to remove abnormal blood components and circulating toxins whilst maintaining adequate circulating blood volume. It is primarily performed to remove antibodies and excess bilirubin in isoimmune disease. The incidence of exchange transfusion is decreasing, secondary to the prevention and improved prenatal management of alloimmune hemolytic disease and improvements in the management of neonatal hyperbilirubinemia. Exchange transfusion is a potentially life-saving procedure that is done to counteract the effects of serious jaundice or changes in the blood due to diseases such as sickle cell anemia. The procedure involves slowly removing the person's blood and replacing it with fresh donor blood or plasma. An exchange transfusion requires that the person's blood be removed and replaced. In most cases, this involves placing one or more thin tubes called catheters into a blood vessel. The exchange transfusion is done in cycles. Each one most often lasts a few minutes. The person's blood is slowly withdrawn, most often 5 to 20 ml at a time depending on the person's size and the severity of the illness. An equal amount of fresh, pre-warmed blood or plasma flows into the person's body. This cycle is repeated until the correct volume of blood has been replaced, and after the exchange transfusion, catheters may be left in place in case the procedure needs to be repeated. Neonatal exchange transfusion refers to exchange all or part of an infant's blood supply for certain medical conditions. A double volume exchange transfusion is replacing the baby's total blood volume twice, leaving the intravascular amount the same. A partial exchange is either increasing or decreasing an infant's hematocrit while maintaining a constant blood volume. For patient care, generally, for exchange transfusions to be safe, the patient's blood should be exchanged for blood from a donor that is compatible. Types of exchange transfusion include partial exchange transfusion, double volume exchange, and single volume exchange. Partial exchange transfusion is either increasing or decreasing a patient's hematocrit while maintaining a constant blood volume. It has two methods. The first typically involves pre-transfusion phlebotomy of whole blood followed by a transfusion of packed RBCs. The second involves removing whole blood using an IV in one arm while transfusing packed RBCs into the other arm. The latter is preferable for longer sessions where a larger quantity of blood is being replaced. This helps prevent the chance of shock from lack of blood. Partial exchange transfusions are often done for polycythemia conditions. The accepted treatment of polycythemia is partial exchange transfusion. PET involves slowly removing some of the blood volume and replacing the withdrawn blood with fluids to help dilute the red blood cell concentration. Treatment of polycythemia with PET is also controversial, but it may be associated with earlier improvements of symptoms. Some trials found that there is no evidence of long-term benefit from PET in polycythemic infants, but the estimated of these effects are extremely imprecise due to the large number of surviving infants who were not assessed. Double volume exchange transfusion refers to removing blood that is equivalent to double the blood volume of the patient while leaving the intravascular amount the same. It is mainly used for management of conditions hyperbilirubinemia and hemolytic disease of the newborn. This procedure is typically used after other methods of treatment have been exhausted. It uses packed RBCs resuspended to the desired hematocrit in compatible frozen plasma. It is typically used as treatment for jaundiced newborn infants, as it is shown to reduce brain damage as well as cure the condition. Lastly, we have single volume exchange transfusion. This refers to removing blood equivalent to the blood volume of the patient. SVETs haven't been proven to be less effective in the treatment of jaundiced newborn infants. However, double blood volume exchange transfusions have been the default procedure due to its confidence of reducing brain damage. The simulated blood, disposal blood, and umbilical venous catheter are attached to the four-way stopcock as shown. This model requires a single operator to perform the transfusion.